స్టార్ట్ అయిపోయిందా మేడం? మేడం ఇది ఏదో ఓకేనా? నో ప్రాబ్లం కదా? ఇది ఏమైనా కనెక్ట్ చేసేది ఉందా మేడం? లేదు కదా? Good morning everybody. Today we are going to discuss regarding Monteggia fracture dislocation. So I will be discussing the topic under following headings: 1. Definition, history, epidemiology, classification, mechanism of injury, clinical features, management, complications, old neglected Monteggia fracture, and recent updates. Historically, it is described as fracture proximal third shaft of ulna with the dislocation of the radial head. So in 1814, Giovanni Battista Monteggia, surgical pathologist and public health official in Milan, Italy, first described Monteggia fractures. He observed that the original two injuries in cadavers and provided the description. It is a proximal fracture of proximal third ulna and anterior dislocation of the proximal epiphysis of radius. So Monteggia fractures, they constitute about 1 to 2% of forearm fractures. And of the Monteggia fractures, Bado type 1 is the most common, followed by Bado type 3 and type 2, and last is type 4. Classification of Monteggia fractures. Bado's classification. Bado classification classified certain injuries as Monteggia equivalents because of their similar mechanism of injury, their X-ray pattern, and their method of treatment. So type 1, it is anterior dislocation of the radial head with anterior angulation. So anterior dislocation of the radial head with anterior angulation of the ulnar fracture. You can see here that this capitulum should articulate with the radial head. You can see that the radial head is dislocated anteriorly. This is anterior, this is posterior. So this is dislocated anteriorly. So anterior dislocation of the radial head, and this fracture is angulated anteriorly. Okay, ulnar fracture is angulated anteriorly. So this is anterior dislocation of radial head, anterior angulation of the ulnar fracture, which is type 1 Bado. So type 2, it is posterior dislocation. Type 2, it is posterior dislocation of the radial head with posterior angulation of the fracture of ulna. Type 3, it is lateral dislocation of the radial head with lateral angulation of the fracture of ulna. Type 4, any of the type 1, type 2, type 3 injuries with shaft of radius fracture, additional shaft of radius fracture is type 4. So you can see here the radial head should articulate with the capitulum. You can see the radial head is dislocated anteriorly and there is anterior angulation. So that's why there is type 1. Type 2, you can see that the capitulum should articulate with the radial head. The radial head is dislocated posteriorly and there is posterior angulation of the ulnar fracture. So it is type 2. Type 3, you can see that the radial head is dislocated laterally with the distal humerus and there is lateral angulation of the ulnar fracture, lateral angulation. So hence it is type 3. And type 4 is, you can see here the radius is intact here. The radius is also intact in type 2. The radius is intact in type 3. But in type 4, the radius shaft is also fractured. So any of the fracture of the ulna with the dislocation of the radial head, any of type 1, type 2, type 3 injuries with shaft of radius fracture, additional shaft of radius fracture, it is type 4. Type 1 equivalents. What is equivalent? Equivalent is any injury with a similar mechanism of injury, any entity of the around the elbow with a similar mechanism of injury, similar method of treatment like Monteggia, similar method of treatment and similar mechanism of injury, they can be classified as equivalent. So type 1 equivalent. Type 1 is anterior dislocation of the radial head with anterior angulation. So you can see here any isolated anterior radial head dislocation, isolated only anterior radial head dislocation, fracture of the ulna with fracture of radial neck, fracture of the ulna and fracture of radial neck, isolated radial neck fracture. This is a radial neck, the isolated radial neck fracture. Fracture of ulna diaphysis with olecranon fracture with posterior dislocation of the ulnohumeral joint, with or without fracture of proximal radius. These are all type 1 equivalents. The method of treatment is similar in all these kinds of injuries. That's why they are classified as type 1 equivalent. Type 2 equivalent. What is type 2? BADO type 2 is posterior dislocation of the radial head with posterior angulation of the ulna fracture. So type 2 equivalent is posterior elbow dislocation, can be considered as type 2 equivalent in children. X-rays, AP and lateral X-rays of the forearm, X-rays of the joint at either end of the forearm, particularly the motion of the radial head, position of radial head. You can see the radiocapitellar relation. What is the relation between the radial head and capitellum of the distal humerus? The radial head articulates with the capitellum of the distal humerus. The ulna articulates with the trochlea of the distal humerus. So, what is the relation between radial head and capitellum on the X-ray? So, what we do is we take a X-ray of the elbow, lateral view, and any line which is drawn along the, you can see here, this is the distal humerus and this is the forearm. You can see that the radial head articulates with the capitellum. So any line drawn along the shaft of the radius, any line drawn along the shaft of the radius has to bisect the capitellum if the radial head is intact, radiocapitellar joint is intact and there is no dislocation. Any line drawn along the shaft of the radius should bisect the capitellum. One more thing is, any line drawn tangential to the anterior and posterior to the shaft of the radius, tangential, those two lines should enclose the capitellum, okay. If on the X-ray the line drawn along the shaft of the radius, it does not bisect the capitellum, that means there is radiocapitellar joint subluxation or dislocation. So management non-operative, reduction of the ulna fracture to re-establish the length of the ulna by longitudinal traction and correction. So around 10 degrees of angulation is acceptable in a complete fracture. You can see here, by longitudinal traction the ulna is reduced, and when the ulna is reduced there is spontaneous reduction of the radial head. By supination, if you do a supination, there is spontaneous reduction of the radial head. And how to maintain this reduced position? By means of a splint, in 100 degree to 110 degrees, 110 degree supination, okay, and 90 degree to 100 degree flexion. So type 2 fracture Monteggia, it's more common in older patients, accounting for 5% of most series of Monteggia fractures in children. So clinical findings, the elbow region is swollen, it exhibits posterior angulation, okay. Treatment non-operative, by longitudinal traction the ulnar fracture is reduced, and by traction there is a reduction of the radiocapitellar joint and the elbow is held in 60 degree flexion. Here you can see by longitudinal traction the ulnar fracture is reduced, and the anteriorly directed force on the radial head, it reduces the radiocapitellar joint, and we immobilize this limb in 60-degree flexion. 60-degree flexion. Okay. Type 3 Monteggia clinical findings: there is lateral swelling, varus deformity of the elbow, significant limitation of movement at the elbow joint. It is second in frequency to type 1 Monteggia. Injury to radial nerve, particularly the posterior interosseous branch, occurs most frequently with this kind of lesion. Open reduction of the radial head often is necessary because the interposition of the soft tissue between the ulna and the capitellum. X-ray, you can see on the AP X-ray, you can see that the radial head is dislocated laterally and there is angulation laterally. Radial angulation at the fracture site is common to all lesions. Treatment non-operative, same thing, but longitudinal traction and valgus stress. Valgus stress, the ulna is reduced in position. Radial head may spontaneously reduce with maintenance of the ulnar length. Ulnar length and alignment must be maintained to ensure the radial head reduction. You can see but longitudinal traction, valgus directed force, we can reduce the radial head. Maintenance of reduction by means of a long arm splint with flexion at 110 to 120 degree, it improves stability. Okay. So here you can see the elbow is extended, traction is given, valgus directed force, it reduces the radiocapitellar joint, supination and immobilization in flexion 110 degree flexion. Type 4 lesions, it is relatively rare in children, approximately 1%. Type 4 lesion is similar to that of type 1 lesion, but the radial shaft additionally fractured. Radial shaft is also fractured. Most often it requires a open reduction internal fixation. Okay, and particular attention should be given to neurovascular status. There is increased risk of compartment syndrome. Treatment closed reduction can be attempted, but most often it may require an open reduction internal fixation. Elbow is immobilized in long arm cast for 4 weeks. Short arm cast can be used for additional 4 weeks while the range of motion at the elbow and forearm has begun. So first 4 weeks you put a long arm cast, and after 4 weeks you put a short arm cast. So type 4 it is, you can see longitudinal traction, reduction of the fracture fragments, reduction of the radial head, and maintenance of reduction by means of a splint in with flexion 100 degree, 110 degree flexion and supination. Monteggia fractures are fractures of necessity. That means Monteggia fractures are kind of fractures which require surgical fixation. A trial of closed reduction, manipulation and reduction can be applied, can be treated in children, but usually they require open reduction, internal fixation by means of plate or nails. Okay. There are two indications for operative treatment. One is failure of ulnar reduction, failure of radial head reduction. So what can we do? If the ulnar fracture has to be reduced, we can reduce the ulnar fracture by means of closed manipulation reduction and stabilize the ulnar fracture by means of a 3.5 mm dynamic compression plate or dynamic compression plate or intramedullary nail. Okay. So failure of radial head reduction. What happens if the radial head is not getting reduced, we do a open reduction and we do a radiocapitellar K-wire to maintain the reduction. So radiocapitellar K-wire to maintain the reduction. So what is the surgical approach? It is Kocher's approach. Incision begins laterally. Kocher's J approach. The interneural plane is between the extensor carpi ulnaris and anconeus, which is called the Kocher's interval. Kocher's interval because it safeguards the posterior interosseous nerve. Another approach is called the Boyd's approach. Boyd's approach. If the reduction is unstable, repair or reconstruction of the annular ligament is done by means of a transcapitellar Steinmann pin, transmetaphyseal pin from the radial neck into the ulnar proximal metaphysis. Ulnar fracture can be reduced by means of a intramedullary nail or plate, dynamic compression plate or locking compression plate. You can see here proximal ulnar fracture is reduced and stabilized nicely with the help of a dynamic compression plate. Here you can see another case where the proximal ulnar fracture is reduced by means of a reduced and fixed by means of a dynamic compression plate. Here you can see this is a type 4 Monteggia where you can see that the radius shaft is also fractured. So what we did is we stabilize the ulnar fracture by means of dynamic compression plate, stabilize the radius fracture also by means of a dynamic compression plate, and probably the radiocapitellar joint was unstable, so we had to do a radiocapitellar K-wire, transcapitellar K-wire into the radial head to maintain this reduction and put a splint here. You can see here that this is a splint, and this splint is applied for at least 3 weeks, after which this K-wire is removed and elbow is mobilized. Complication: neglected Monteggia, nerve injuries, periarticular ossification and compartment syndrome. Old neglected Monteggia. There is one procedure which is called Kalamchi procedure. Kalamchi procedure. Okay. Annular ligament reconstruction. Neglected Monteggia because of the failure of the radial head reduction. Because of soft tissue interposition, we need to do a open reduction, internal fixation of the radial head, and also the annular ligament reconstruction. Annular ligament reconstruction. You know what is annular ligament? Annular ligament is a ligament which encircles the radial head. Radial head. Okay. So we need to do annular ligament reconstruction with the help of a triceps tendon, triceps aponeurosis, or fascia lata. It can be done. Okay. You can see that central slip of triceps can be used to reconstruct the annular ligament. Annular ligament is a ligament which encircles the radial neck. Radial neck. Fascia lata graft can also be used. Osteotomy is Kalamchi procedure. A drill hole ulnar osteotomy is to obtain reduction of the radial head in 2 patients. Mehta also devised an osteotomy which is a proximal ulna stabilized with a bone graft. For suppose the radial head is not getting reduced, we do a ulnar osteotomy. We lengthen this ulnar length by 1 centimeter so that the radial head gets reduced. We pass a transcapitellar K-wire and we do a bone grafting here, which is called the ulnar osteotomy. This is called the Hirayama's distraction osteotomy. Hirayama's distraction osteotomy. So we stabilize this fracture by means of a plate and we put a bone graft here. Nerve injuries. There is 10 to 20% incidence of radial nerve injury. The posterior interosseous nerve, the deep branch of the radial nerve, which is most commonly injured. Okay. Why? Because the posterior interosseous nerve encircles the neck of the radius. Neck of the radius. Very rarely median and ulnar nerve injury can be seen. Nerve function usually returns to normal within 9 weeks of reduction because the kind of nerve injury is a neuropraxia, traction injury of the nerve because of the fracture fragment, because of the radial head dislocation. There is traction of the radial nerve, which is neuropraxia. And neuropraxia, usually the nerve recovers between 6 weeks to 6 months. Usually approximately 9 weeks, most of the nerve injuries recover. Periarticular ossification, there are two types of ossification. One is around the radial head, two myositis ossificans. You can see here around the radial head there is extra bone which is the periarticular ossification. You can see here also there is an extra bone here which is myositis ossificans. So in any elbow injury we need to give a prophylactic dose of indomethacin to prevent a heterotopic ossification and myositis. Recent updates. Hirayamas osteotomy. As we have already discussed, there is simple transverse osteotomy of the ulna to distract the ulna so that to reduce the radial head annular ligament reconstruction, and then we stabilize the ulnar fracture by means of a plate, and the distraction between the fracture fragments of the ulna we put a bone graft. Neglected Monteggia fracture by ulnar lengthening can also be done by means of Ilizaro technique. It can also be done by means of an external fixator, radiocapitular joint can be reconstructed by means of an external fixator. Thank you.